edema. So what is urticaria? Urticaria is a skin manifestation due to dilated vessels with extreme itching, redness, wheals, and there are wheals of varying size and described as fleeting. Erythema multiforme is a more pronounced variation of urticaria characterized by target lesions. So erythema multiforme is a type of urticaria which forms target-like shape of urticaria. Erythema multiforme. Remember this. Angioedema is similar but a more deeper. Like urticaria is a skin edema, but angioedema is actually the edema of the mucosa and the submucosal tissue, especially on the face, lips, eyelids, and it involves the dermis. Edema in the dermis involving the face and neck and distal extremities. Angioedema of the tongue, lips, and face can cause airway obstruction. It can be hereditary as well as acquired. So ACE inhibitors cause acquired angioedema due to bradykinin release. Bradykinin. How do you treat angioedema? You use a C1 esterase inhibitor, बेरीनट और डानाजोल भी यूज़ करते हैं. आइकैतिबांट, इकैलेंटाइड, डानाजोल, है ना. आइकैतिबांट, इकैलेंटाइड. Hereditary angioedema is autosomal dominant disorder due to C1 esterase inhibitor deficiency. Which is due to either low levels of C1 esterase inhibitor or a dysfunctional enzyme, and 25% cases are new mutations. This disorder is characterized by acute edematous reactions involving the upper respiratory system, soft tissues of the extremities or trunk, or GI tract. These attacks can last from a few hours to 1 to 2 days. Minor trauma often precipitates an acute episode. However, triggers are more often elusive. You can't really tell. Suddenly, you just wake up with edema. Facial edema, fingers edema. Typical treatment for allergic reactions like epinephrine, corticosteroid, and antihistaminics don't work in these patients. Epinephrine, steroids, antihistaminics don't work. The best screening test is C4 levels. A C4 level less than 30% of normal suggests hereditary angioedema. Acute attacks can be shortened by C1 esterase inhibitor levels. C1 esterase inhibitor को supplement कर दो, either human plasma derived or recombinant. The bradykinin 2 receptor antagonist icatibant or kallikrein FFP may also be used if C1 esterase inhibitor is not available, although the dosing is not standardized. With attenuated androgens such as stanozolol or danozol can also be used. In food allergy, fatal reactions can occur without a prior allergic history. Less than 25% of the patients who die of penicillin-induced anaphylaxis actually exhibit allergic reaction during previous treatment with the drug. So it is possible that you were fine with penicillin before, but now suddenly you developed anaphylaxis with penicillin and you died. Nature just wants to kill you, basically. Now in acid-base disorder, this is a small diagram of how our body handles H+. Either we ingest it with acid, we excrete it. How do we excrete H+ in our vomitus? It gets metabolized. It is there in hemoglobin. It binds to protein. Actually, H+ and K+ fight for the same location in the protein. So H plus and K plus go in the same direction. Whenever there is alkalosis, H plus is low, the potassium has more seats, so it binds to the proteins, and then we have apparent hypokalemia in our body, alkalo. Okay, and bicarb, H plus is converted to bicarb, H2CO3 with carbonic anhydrase, which converts H2CO3 to CO2 and water and then excreted. Carbonic anhydrase converts H2CO3 into CO2 and water, which is then excreted. For every drop in the albumin level by 1 gram, the normal anion gap range should be lowered by 2.5. Metabolic acidosis causes are loss of bicarb like vomiting, enterocutaneous fistula, and renal loss of bicarb in CKD patients. Ethanol should never be considered the cause of any significant metabolic acidosis. What is osmolar gap? It helps to identify methanol and ethylene glycol poisoning from other etiologies. Its formula is 2 into sodium plus ग्लूकोज बाई 18 प्लस 1 बाई 2.8 हम लोग बोलते थे, तो 2.2 इंटू सोडियम प्लस 1.4 इंटू ग्लूकोज प्लस 1.2 इंटू यूरिया प्लस 1.2 इंटू एथेनॉल. सो 2 सोडियम, 1.4 ग्लूकोज, 1.2 यूरिया, 1.2 एथेनॉल. 2 ना 14 ग्लूकोज, 2 इंटू सोडियम, 1.4 इंटू ग्लूकोज, 1.2 इंटू यूरिया, 1.2 इंटू एथेनॉल. What are the causes of normal anion gap metabolic acidosis with a tendency to hyperkalemia and hypokalemia? So hyperkalemia will occur in resolving DKA, renal tubular acidosis 4, obstructive uropathy, Addison's disease, and some acid ingestion. Hypokalemia will occur in RTA 1 and 2, acetozolamide, and diarrhea. So resolving DK, RTA 4, obstructive uropathy and acid ingestion is your hyperkalemia. Hypo किस में होता है? RTA 1 and 2 में, और आपका diarrhea and acetazolamide, acidosis with hypokalemia. Now very important slide. What are the indications of bicarbonate in metabolic acidosis? So if there is severe loss of bicarb is less than 4 milliequivalent per liter, then you need to give. If the pH is less than 7.15, severe acidemia, pH less than 7.15 in case of a hagma with increased chloride. So 3 indications are there. Severe hypobicarb, yani bicarb is less than 4, then you have to give in any situation pH less than 7.15 due to metabolic causes and increased chloride with hagma. After successful treatment with bicarb, and overshoot alkalosis may occur. Bicarb has 1000 milliequivalent per liter of sodium load. So bicarb has 1000 milliequivalent per liter of sodium, while normal saline has only 154 milliequivalent per liter and plasma has 140 milliequivalent per liter. So it's like 7 to 8 times of what we are used to handle of the sodium. For every 1 ml of soda bicarb, you are giving 8 ml of normal saline worth of sodium, 8 times sodium than what we have in our body. Then there is respiratory alkalosis. What conditions cause respiratory alkalosis? So conditions that will reduce CO2 production and increase CO2 excretion, mainly in CNS tumors, stroke, infection, pregnancy, fever, hypoxia, salicylate toxin, anxiety, pain, and iatrogenic in mechanically ventilated people, high altitude. How will we treat it? So the patient with anxiety and hyperventilation, do not use a paper bag rebreathing. It may lead to hypoxia. You need to just calm the person down and sedate them mildly. Acetazolamide may be used in severe cases. This is an important table. So what is the checklist for evaluation of dehydration risk? So the mnemonic is dehydration itself. D for diuretics, end of life. Why end of life? Because the elderly people who are critical cannot really have a proper thirst response and don't ask for water. Patient has high fever. Yellow urine turns dark. Dizziness. When you stand up, you are dizzy. Orthostasis. Reduced oral intake. Dry axilla. Tachycardia. Incontinence. Why? Because the urinary incontinence will actually have the person drink less urine. Oral problems, person can't swallow. Neurologic impairment, person can't drink water. Sunken eyes. So diuretics, end of life, fever, yellow urine, dizziness, reduced oral intake, axilla is dry, tachycardia, incontinence, oral problems, neurologic impairment, and sunken eyes. Hyponatremia, according to Tintin, it is less than 138 milliequivalent per liter. But symptoms start only less than 135. I don't care. Less than 138 is the cutoff. There are different types of hyponatremia. First is hypervolemic hypernatremia. So you have both more volume and more sodium in your body, like CHF, cirrhosis, nephrotic. Hypernatremia. Hypovolemic hyponatremia. Okay, not hyper. I literally found a typo in Tintin. Wow. CHF, cirrhosis, nephrotic will cause water loading, thus causing hyponatremia. Normovolemic hyponatremia. Psychogenic polydipsia. Normovolemic, you need to remember it. Psychogenic polydipsia, steroid deficit, glucocorticoid deficit, hypokalemia, drugs and SIADH. So कैसे याद रखेंगे? इसे याद रखना ज़रूरी है. Normovolemic. तो normovolemic, remember I am a PG. I have psychogenic polydipsia. I used to have it and I am a PG. So PG and SIADH. एक पीजी है सपोज, उसको एक SIADH पेशेंट मिला, जो मुझे बहुत बार मिला है. सो पी से साइकोजेनिक, जी से ग्लूकोकॉर्टिकॉइड डेफिसिट, बिकॉज वी वांट ग्लूकोकॉर्टिकॉइड डेफिसिट, वी डोंट वांट स्टेरॉइड्स टू रोम अराउंड, mess with our hormones, so we want kind of like a glucocorticoid deficits. So the PG is actually sweating because of the hypoglycemia. ऐसे भी काट कर सकते हो. तो PG साइकोजेनिक पॉलीडिप्सिया, ग्लूकोकॉर्टिकॉइड डेफिशिएंसी एंड SIADH पेशेंट जिसको उसको मिला, तो SIADH इज़ अ कॉज, प्लस D से ड्रग्स एंड H से हाइपोकलीमिया इज ऑल्सो अ कॉज. Next, there is hypovolemic hyponatremia. You're losing both water and salt. More salt you're losing. So diuretics, mineralocorticoid deficiency. So glucocorticoid deficiency was causing normovolemic hyponatremia, but mineralocorticoids causes hypovolemic hyponatremia, and there is a salt losing nephropathy. Then there is external hypovolemic hyponatremia and vomiting and diarrhea. What are the causes of SIADH? So infections, vascular causes, malignancy, traumatic brain injury, Guillain-Barré, some drugs, cyclophosphamide, carbamazepine, bromocriptine, amiodarone, tuberculosis, lung abscess, carcinoma of lungs, sarcoma, lymphoma. Opioids, desmopressin. What is the diagnostic criteria of SIADH? So they have to have normovolemic hyponatremia, hypotonic but normovolemic hyponatremia with osmolality less than 275, inappropriately elevated urine osmolality, and more than 200. तो plasma osmolality less than 275, urine more than 200, elevated urine sodium more than 20, clinically euvolemia, normal adrenal, renal, cardiac, hepatic and thyroid functions. 5 चीज़ें चाहिए. सीरम ऑस्मोलैलिटी 275 से कम, यूरिन ऑस्मोलैलिटी 200 से ज़्यादा, यूरिन सोडियम 200 से ज़्यादा, नॉर्मल रीनल, कार्डियक, हेपेटिक एंड थायराइड फंक्शन, एड्रीनल फंक्शन, यूओलीमिया क्लिनिकली. So treatment of hyponatremia when the patient presents with severe neurological symptoms, vomiting, seizure, reduced GCS, cardiorespiratory arrest, we need to start bolus 3% saline. Chronic hyponatremia में the sodium correction should be slower than acute. In chronic hyponatremia, the correction should not exceed 6 milliequivalent in a day, while in acute you can go up to 6 to 10 milliequivalent or sometimes even 12 milliequivalent depending upon the severity of symptoms of the patients. So treatment of hyponatremia in seizures or coma, assess for indication of 3% saline. If there is severe symptoms like seizures, coma with impending brainstem herniation, reduced GCS, infuse 100 to 150 ml of 3% saline in 20 minutes. Then measure the sodium after each 3% saline. Stop the 3% if you improve 5, मतलब 5 बढ़ गया है ना, और may repeat a 150 ml of 3% saline up to total 3 doses maximum. आपका 1 डे में टोटल 8 to 12 से ज़्यादा नहीं जाना चाहिए और 2 डेज़ में 18 से ज़्यादा नहीं जाना चाहिए इंक्रीज़ सोडियम का.